Hey, this is Jim Hoffman from EMS Office Hours. Thanks for joining me today on this podcast. We have Jonathan Fight on with us today. Jonathan, thanks for joining.
My pleasure. Thanks for having me, Jim.
So, I guess I put a survey out there online. Just sort of talking a little bit about ADHD and EMS are some of the struggles that people have with it. So I wanted to get on with you and maybe talk a little bit about that and just sort of go over it. Before I do, Jonathan, do me a favor real quick. Just sort of introduce yourself and kind of where you're at when it comes to EMS and all.
Sure. So thanks again for having me here. So Jonathan Fight, I run a company called Beyond Lucid Technologies. Been in mobile medicine for. Sorry, I thought that message was for me. This is mash the like button. I'll like me. Sounds great, I guess. It's what we're all about here, right? We're talking about liking yourself and appreciating what you do all day. Got started in this business in 2009. Basically, so I guess we're going on 12 years now. And I'm on the technology side. So we started out focused on data capture and analytics and things like that, and really moved into stringing together data over time for things like community paramedicine, substance use intervention, and now tracking for COVID-19, syndromic surveillance. We're working with folks who are have end-of-life orders, really trying to focus on the value of the data that people collect, and recognizing that there are others in the ecosystem who need a part of it. So really looking at centralizing mobile medicine in all of its flavors into the healthcare continuum where it belongs, recognizing that you're the tip of the spear, and so many issues that this industry faces, I think, have to do with people not being able to appreciate what goes on in the back of the rig. Or at the patient's side. And so my mission and mantra is really about that. Obviously, in the past couple of weeks and months between COVID and now, it's snowing in Texas, there's all kinds of reasons why people need to appreciate what it is that you guys on the front do. And I'm not in the truck, right? I mean, aside from virtually, I suppose. So my job really is to make sure that we're there around the clock to support. And the reason why I wanted to talk to you today, as you mentioned, the ADHD connection. So I have Tourette syndrome. I've been pretty forward about that. I think for the reason that a lot of people with conditions like, neurological disabilities, really any kind of disability, but certainly the ones that are non-obvious. Give me a few minutes. You'll see. If I seem twitchy on your screen, it's probably not your monitor. It's just me. There's really not. I suppose there are lots of people who live with things that are beneath the skin, right? That you can't see. I used to get very offended as someone living with a condition that is not necessarily obvious. Depending on what I'm doing, depending on how my day is going, depending on how much sleep I've had, you can see my face is a bit twitchy. This is what I do, right? There are other people who have very different experiences, and people assume, right? And they don't necessarily know what's going on. If you're blind or deaf or can't walk, those types of things, they can be very easy to tell, right? But when you have something that's below the skin, I feel like there's a lot of people who make assumptions. I can tell you in my personal life, I've had I literally at one point had a master's degree. It's kind of how I got into this crazy business, but I thought I was going to go to medical school. Then I ran headlong into organic chemistry. We didn't see eye to eye. But I was sitting in a program with a professor at a university. She was the director of admissions. I had a master's degree at that point. I was wearing a suit. I had already run a business. And in the middle of my interview, she stopped me to say, "Are you high?" I thought, are you kidding? Do I seem high? Do you want to get high? Like, I don't really know what you're asking me here, but it's just the most remarkable thing. And so I feel like one of the things that I love about this business There are some unbelievably talented people. You know this. You talk to these people, right? You are one of them. People who are incredibly passionate, incredibly good at what they do, and incredibly humble, right? And I feel like one of the things about living with a disability or a different ability, whatever you want to call it, is that it leads to an enormous amount of empathy, right? And I think that's one of the most important things that we can have in certainly in life and in healthcare. But when you look at mobile medicine, I think you guys get a dose of it on every call, right? Whether it's the stupid call that really did not need to call, or all those calls where you go into the house and you're realizing like there are children living here. How is there humans living here, let alone children living here, right? And
Sure.
and I remember I've gone on those. I mean, I've I may not work in the back of the truck, but I've been on it more times than I can count. Um, and just there are those calls where you go in and you realize that these people are calling you because they don't have anybody else. And that level of empathy is something that I think living with a disability can actually become kind of a superpower in this business, because you get an ability to relate to people. Again, looking at folks and saying, I really had no idea how much crap you were going through in your life, but I go through my crap too, right? And I don't tell anybody about it, just like you might not tell anybody about it. And everybody has something, right? But in this industry, people tend to get it. And I found that since I was first started in this business, the fact that I'm a twitchy guy, people kind of, could look at me and be like, I get it. It's no big deal. I see you, you know? And that is an unbelievably compelling feeling. It makes you feel very home, as opposed to in some other industries that are far more superficial. Anyway, that's kind of why I wanted to make sure I talked to you here, because I think what you were asking about, there are a lot of people who will talk about their experience living with something like ADHD or obsessive compulsive conditions, or other things. Tourette's is a schizoid disorder, right? So there's all sorts of aspects that people don't understand. But I have found that the ability to relate is a very compelling tool in an industry that deals with people in some of the worst moments of their existence.
Well, it's fun. I have Josh here, Jonathan. Let me put him in. He's been
Sure.
kind of hanging out on the sidelines.
Hey there.
Josh, thanks for popping
Hey,
in.
Jonathan.
I know you're on a tight schedule today.
I caught all your intro, and just want to commend you for
Thank you.
For watching our show and knowing about it, to come out and say, hey, this is the way I can reach out.
Sure, I
We
appreciate
love
it. Yeah, thank you. I mean, like I said, I think it's one thing to scratch the surface that everybody else has already scratched, and it's another thing to say, let's talk about things that sometimes go unsaid. Those are the places where I want to try to contribute if I can.
And I have a little bit of your background, just a little bit of reverse. I started out my career in IT, and then went to the insanity that is going to people at their worst possible moment, as you put out there. And
Sure.
that's a very, very poignant observation, because
Well,
I have to. When I've taught a couple of classes here and there, and when I have had my students, I've always said, you don't know what you're walking into, and that's certainly an aspect of danger and scene safety and things like that. But the flip side is, look at your patient. Understand that they're calling you at what can be their worst life experience, ever, and you're the person. You're the face that they're looking to for comfort, for security, and for some sort of definition of what we're going to do from here.
Yeah, I think that's right. And one thing that I find so very interesting, and again, for me, it's a really source of passion. These are long days we work in this industry, right? No matter whether you're in the truck or you're serving the truck, they're long days. I talk a lot about the phrase, if you're working, we're working. We live that on our sleeves. But I think it's interesting when you look at the evolution of the business to focus on things like community paramedicine, right? And it's interesting how the context of 911 is reactionary, right? Just by its definition, resiliency and picking people up and pulling them out of vehicles and all the different things that 911 is. But when you look at community paramedicine, mobile integrated health, whatever you want to call it, and its ilk, you end up with something I would refer to as pro-actionary, I guess, to sort of coin a conjugation. And what's really, but what's really interesting is to think that the folks who are in that level of care, right, probably don't want to be there. They don't have anybody else. And so imagine a situation where what you just described of, people, and I guess I described sort of people at their worst moments, is almost taken to the extreme of they live there, right? That's their baseline condition. I mean, I'm sure there is a small subset of people in this world that said, I really want to live under a bridge. But that's a pretty small subset, and those folks probably aren't calling 911 habitually, right? Most of the folks who live in tent cities do it because they don't have any other place to go. And so I think the role that we get to play collectively is to recognize that those people need you. And so they've run out of other options. And I think it's interesting how folks often refer to EMS, mobile medicine, as sort of the referral of last resort. But the fact is, it can also be the referral of sort of the start of the next phase, right? I think when you look at that's one thing I find incredibly compelling when you look at sort of the value propositions that can be offered by these longitudinal care models, is you want to be able to show how you made people better, not just that you reacted to them. And again, there's so much of that is about empathy and realizing that if they had a choice, they probably wouldn't be calling you. Now they've gotten to the point where they've exhausted all the other options. So now you have the opportunity to really make an impact, lift them up, do all the things we do best, and keep them there. To me, that's incredibly emotional. I can't think of anything that is a greater calling. That it's not just scrape you off the sidewalk; it's keeping you from falling down again. And it's so underestimated that is a huge function that this industry does.
I have a quick question because I missed it at the very beginning. Did you say that you did work in ambulance? You do work on an ambulance?
Oh, I'm not a clinician. I'm a technologist.
Okay. So you're the motor behind our data source and transference of the PCRs and whatever else, scheduling.
Yeah. So my business, I got into this business. Long story short, I joined the military on September 11th. My MOS for the military occupational specialty, for those who don't know the parlance, was 91 Whiskey Field Medic. So I actually had planned to become a medic in a military context. It turns out Tourette syndrome and the United States Army don't see eye to eye, kind of like me in organic chemistry, I suppose. I actually had to work really hard to get into it. The waivers process is its own fascinating challenge. But basically, I was not long for the military, but I got a chance to understand pretty intimately sort of what's involved and really the overlap between military medicine and rural EMS. They are remarkably aligned. So that was really kind of what got me into this. I'd like to think I found another way to serve. And so we started in EPCR, sort of morphed into pre-hospital health information exchange. Now my main focus is making sure that the data that gets collected gets where it needs to go. And so it's really about the idea that the work and the brain power, the clinical expertise that folks in the truck bring to the encounter, someone else needs that, right? So if it goes onto a piece of paper that gets left in a box at the ED, that's a wasted opportunity. Now, the other thing that I talk so much about is the world at large thinks EMS is unidirectional, right? You pick them up, you drop them off, you go on to the next call. What we are finding more and more, both explicitly and implicitly, is someone else needs that information. It needs to come back, right? So whether it's outcomes data and process improvement or sharing that with social resources, someone's going to need that information, know how this patient is doing. And so my bailiwick, my organization, is all about the pipes. We refer to as the pre-hospital pipes, kind of moving the data where it needs to go, making sure it's compliant and controlled and safe, but also available, because the real-time availability is a critical missing factor in care. Time is of the essence, right? If you talk about a patient who's living under a bridge, dealing with COVID, dealing with tuberculosis or substance use, if you don't get their data back for 3 days, they may have called 911 6 times in that 3 days. Right. So you need to make sure that data is available as soon as possible. And that's really what we try to focus on. but it's really all about making sure that people have an appreciation of the context of the patient, because we look at, like, I've written an interesting couple pieces about San Francisco. So I'm based near San Francisco, and we've got a bit of a drug problem in San Francisco.
Really?
Yeah, right. But what's a really remarkable thing? It is something I don't think people realize. Certainly in San Francisco, they definitely don't realize this. Is we have 3 911 providers in the city and county of San Francisco: the fire department, AMR, and a third provider, a private ambulance service. And so the city's basically broken up into 3 sections, and because of the way the data is basically not shared at all, is you can cross the street from one district to another and get picked up again, right? Given fentanyl again, and or whatever else, and basically obtain your narcotics that way, because those 2 services, the fire department and AMR, don't talk to each other. So the idea that you can actually have people taking advantage of those broken connections to make their situation worse is something that we are trying to solve, especially when you look at it at the belly of the tech beast like San Francisco. So that's what I do. And again, to me, it's really about the question of, do you know your patient? I've pissed off people, and this kind of comes back to obviously the disability question pretty intimately. But I've pissed off some people when I talk about community paramedicine. I say it's not a clinical project; it's a data project. They look, well, it's a whole different way of taking care of patients. Not really. I mean, you take care of patients the way you need to take care of patients. That's what mobile medicine does. The question is, do you know who they are before you get there? Right? Do you know that this person has a neurological disability? Do you know that they have a history of childhood trauma? Right? Do you know that they have a certain language limitation? Right? Those are the questions that make community paramedicine what it is. And I'm all about teaching that empathy to people, to say, ask who your patient is, not just what the context, not just what you need to do to them right now.
If you've seen enough of the show, you probably know that the community paramedicine is a little bit of a thorn in my side, because I think it's a waste of resources, and it's competing with the visiting nurse who have been doing it for 100 years.
Sure.
And certainly. And certainly, with that, community paramedicine was sort of designed a little bit from the conference room and then the rest on the fly.
Sure.
It was like, let's do this great idea. These are the skill sets we need. We can use these paramedics. We can train them, for the more proactive medicine, not the reactionary medicine, and send them out in the field. But on the same side, you could have sat there and said, visiting nurse, let's look at some of the things that we can now that we've lessons learned, and let's integrate them in. So
I agree with you on a compelling level.
Right.
So let me preface with and maybe this will be, I would say it'd be news, but I've said this many times. The common understanding of community paramedicine is based on a mistake. It's based on a math error, and that's where being a non-clinician. My organization is the only company in this business founded by 2 non-clinician MBAs. I can't tell you how to stick a tube down somebody's throat, but I can tell you what it's worth. And it's based on a number of errors associated with the concepts like readmission avoidance, because you are absolutely right. Absolutely right. What's interesting, and when you start to sort of unpack the potential of this model, because I am a firm believer in the concept of community paramedicine, just not the way it's deployed in most cases because of that error. But imagine a situation, again, speaking about people, forget Tourette syndrome or even ADHD. Let's talk about schizophrenia, sort of take it to its logical conclusion, right? If you are a visiting nurse, you are historically, stereotypically, but it's not wrong, many visiting nurses are women. Not all of them, of course, but many of them are women. Many of them are immigrants. Many of them are probably shorter than most men, probably less physically strong than most people in EMS. Again, these are clearly stereotypes, and there are going to be exceptions to all of it, but I don't think that's the craziest thing to suggest, based on who tends to go into that profession, right? You are very well attuned to determine if somebody is taking their medications, if they are within range on their vitals, if their meds need to be refilled, if their oxygen is in the tank, do they have a fall risk, is their neuropathy getting worse, right? These are all things that visiting nurses do really, really well, right? If EMS, mobile medicine, fire-based, I don't care what you call it, if we contribute by replicating that effort, then you are beyond correct, right? That is also a failed opportunity. However, if you look at patients who are mentally ill with violent tendencies, in particular, folks who may be prone to hallucination, people who, let's assume, for example, you have somebody like with Tourette syndrome that is more severe, that has physical outbursts. Let's assume that you are somebody who may be self-medicating for a variety of reasons. If you are a visiting nurse who wants to go into someone's home and check their pillbox, you have very little interest in the risk of getting stabbed. I think I can make that statement, right? If you are, and by the way, this translates to a business model. I have suggested on more than one occasion that community paramedics, when deployed properly, probably should be eligible for hazard pay. It's not about, because if you think about it, the economics are wrong. There is no, the use of EMS for community paramedicine in a readmission avoidance context is based on an error, right? It is not only a bad business model, it's wrong. And you see that now in the context of the pandemic, probably more than anything, right? Hospitals want every readmission they can get. They don't get penalized in the form of negative revenue. That's actually the source of the error. They don't lose money. They just get paid less money if you bring in a patient who is readmitted. So the point is that visiting nurses, whether you're an independent agency like the Visiting Nurse Service of New York, or if you're a social work division of a hospital, they take on risk when they go into the home, right? The higher the risk, the less they want to be there, basically. So but there is a cohort of clinicians that are really good at going into shitty environments, excuse my French, being geared up properly, dealing with violent situations where they don't know what they're dealing with, et cetera, et cetera. And those are mobile medical professionals, right? Who go into that environment every day. You roll up hot, whether you're going in, prepared to get stabbed and deal with somebody who's out of well, if you can offset that risk for them. Sorry, just to finish the point. If you can take on that risk for the nurse service, right? You are no longer competing with the nursing service. You are now actually assisting the nursing service in a specialized subset for which you are uniquely qualified. And that is something that I have wondered why more people don't know how to do that math. It's actually not particularly complicated. But you can look at someone and say, if it would cost you net total for personnel, for insurance, for risk, for morale, let's say it would cost you $1,000 per encounter when you actually factored everything in. If you offload that risk from your books and hire your nearby ambulance service to go and do that for you, they would be doing it anyway if they called 911. So instead, you're offloading all kinds of risk off of you onto something that they're used to doing very well. And now they become your ally as opposed to this political opponent. And now everybody gets better. And that's not an impossible thing to do. That motive is starting to happen in some really interesting places in Connecticut, South Carolina, and Texas. They are starting to basically rejigger the model. And I like to think I've been a part of that, which is pretty exciting. Sorry, go ahead.
No, I'm not sure that I understand that you're looking at it from the whiteboard perspective, where you have the data, you're sort of jiggering it, to use your phrase, to see how we manipulate the scenario to the best outcome. I would push back and say the majority of visiting nurse calls are established patient wellness checks or established patient, so they're established patients. So the idea of the unknown is is less of a factor. You probably know these risks better, and if the system works the way it possibly should, if you have somebody with the tendencies where they could be danger, you would send another person with that nurse, or two nurses together or whatnot, for specially handling that patient. I absolutely agree to a point on the aspect of taking a seasoned paramedic who's been in the field and has had those missteps, because let's be honest, you really don't know to watch out, until you're taught to watch out. You sort of, you do the thing when you're in class of scene safety and everything, but it becomes more of a mantra than a living fact. And we've talked, and this is something we've discussed on the show as well. When I first started out, I worked in a very poor section of the city, a lot of slums, a lot of poverty, and the abuses that go along with that type of environment. And my partner was like, look, we came in and there was a big kitchen knife on the table a couple of feet away, and my partner just started talking to the patient, and at the same time picked up the kitchen knife, held it behind his back, and sort of shoved it at me to take it. And then it was like, through eye contact, it was like I knew enough to look around for other objects of destruction. I'm not sure how that really translates with value in the repetitive wellness check, patient upkeep model.
You make an excellent point. I think it's very contextual. I don't think the model fits everywhere. But for example, we just deployed a program about 2 weeks ago in Connecticut that is in many ways first of its kind, involving EMS sort of at the center of an ecosystem, but it is specifically focused on substance use, right? And so, or abuse. So it really looks at patients.
Well, depends on your point of view.
Yeah, fair enough. Well, it falls in, and again, I think this sort of ties back to the initial topic here of disability and sort of the underlying what you don't know about the patient, is that the chronically acute, as I've been phrasing them recently, sort of this not just in the system over and over again, but in the system at risk of harm to themselves or others, can be over and over again. I think can be a combination of several things you just mentioned. On the one hand, do you know the patient? Have you seen them before? Are you going to see them again? And so you sort of put them into this theoretically eligible for CP type context. On the other hand, there could very well be an urgent or acute or emergent context when you get there, right? Did this person use and therefore hallucinate and therefore take that knife thinking it was something else, stick it in their arm, and now you're dealing with something else, right? I mean, these are not, it doesn't take a lot of imagination to get there, right?
Right.
And so I think your point, very well taken. The proliferation of community paramedicine. Are there too many programs that call themselves that? Yeah, without a doubt. But there are. It has become a fad in many ways. But
you have a lower paid staff, so it costs you less to put it out in the field, and you can take in about the same amount of money. On a business level, that's a pretty good model to make more money on.
Okay, well, I mean, if it were, they'd probably be more successful than they are. So I think that's probably worth a discussion. But I think again, sort of bringing it back to, I don't want to make sure we don't hijack this too much in that direction.
Yeah, no, I really wanted to move back to
your
taking it from a perspective of an individual who is out in front with a disability, and sort of sees the world with a slightly different lens now. What does that bring to the model that we're facing and the changing environment we're facing?
Well, to me, I think it's the sensitivity. Again, going back to empathy, and I don't mean that to sound hokey. I think when you when you come in with the realization that you as an individual have experienced being that misunderstood person, have experienced, and I don't know if I want to use the word pain, but let's call it frustration of being the person for whom the voices are incredibly real. Let's call it that, right?
Okay.
For being, I mean, I have personally experienced, and I do think that, Jim, your original question was about ADHD, but I have experienced what it's like to be thrown against the wall by a security officer or a cop, and have them think that, oh, sorry, guys, my thing's ringing. Hang on one second. Just give me a pause real quick. I told them not to do this, but they're doing it anyway. Okay. Sorry about that.
It's quite okay.
You can edit that out. So
Life happens.
To be the person, as I was saying, who a security guard or a cop has thrown up against the wall, thinking that I was whatever they thought, right? And I think, when I was a child, I was misdiagnosed. I was diagnosed with ADD, OCD, and other related spectrum disorders, basically disorders of the basal ganglia. Since I was a child, I was on medications that should never be given to a child. Things, literally horse tranquilizers, blood pressure medications, things that are certainly not contraindicated, but unfortunately, things like Tourette's, ADD, OCD, etc., are often, as you know, misdiagnosed or sort of confused for other things. It's very much a trial by error situation. And one of the funny things about giving Ritalin, for example, or its ilk, to a Tourettic, is that it was great for stopping my tics and helping me, it was great for helping me focus, but you give speed to a child or a Tourettic, your tics are going to be off the charts, right? So I couldn't stop moving. I was focused. That wasn't the problem, but I was just all over the place. And similarly, I think understanding, like, you give a person with something like ADHD, and what is the thing that so many people in a 24-hour business do? They drink a lot of coffee, right? I mean, stimulants like caffeine plus ADHD probably lead to some, odd effects. And so I think there is something that you get from having a condition or recognizing and being able to speak about a condition, which, again, not everybody who has these conditions are comfortable talking about them. I am. So being able to sort of say, everybody's got something, and that needs to be accommodated, because what is the positive upside, right? I've talked to people, I've talked to kids in particular about this, how I define happiness as someone living with a disability. I define happiness as mapping your life situation and what you're good at with what you love, right? Finding some way to do that, right? Because of Tourette's, the odds of me doing, I don't know, say being a professional singer, probably less likely. Impossible? No, there are certainly people who've done it, but I have facial tics. It would be hard for me to do that, right? Being in the Army, hard for me to do. Does that mean that I can't be some other way supporting that same effort, right? For example, as a technologist. Right. So taking what your life circumstance and bending it around what you do. And one of the things that, for example, individuals with something like ADHD have a lot of is energy, right? Channeling that into a 24-hour business where you need to be ready to go, probably a great place for them, in fact. You've got to keep it under control. You got to be able to stay on task. So you got to learn how to harness that, right? But it can be like, do you remember the movie Deuce Bigelow, Male Gigolo, back in right? Remember how he deals with things like the Amy Poehler playing the Tourettic, and he takes her to a baseball game, and all of a sudden she's awesome. She's not like this, a sore thumb. I mean, to those of us growing up with this, that was like a guidebook to life. If you curse a lot, go someplace where that's okay. Don't work in a kindergarten.
Right.
So I think that becomes, again, it's a way of sort of harnessing your life experience, realizing that everybody's got something. And if you want to pile drive, it's not to say that you should avoid your dreams. It's to say, can you be creative in the way that you channel that energy and that focus and that ability, so that which would otherwise be a weakness becomes a strength. and I think for somebody who's ready to go, for somebody who is focused on cleanliness, make sure you wash your hands 9 times, right? Just so being in an environment where you need to be clean and sterile, that's good, right? That person might not want to work in a sanitation environment because they're going to freak out all day. But if they need to work where they've got to be comfortable putting iodine on their hands or betadine or whatever, that's probably okay. And so I think that's a very hopeful and optimistic way of looking at this, which is to say, I can empathize, I can channel, I can focus, I can succeed. And what would in other contexts be seen as a weakness becomes a compelling strength. And I use that in the example of my business partner sometimes. My business partner is a big boy. And so it's funny to think that I've used the example of somebody's a couple 100 pounds overweight and you put them on the savannah, that's bad. They're going to get eaten, right? You take that same person and you put them in Alaska or in the North Pole, they're eating me, right? Yeah. And so, context is incredibly important. I mean, evolution is like that, right? Is your set of contexts appropriate for your niche? And I think that when Jim, when you sort of put out this ask for people who are in this industry with conditions of neurology and psychiatry and mental and behavioral health issues and so on and so forth, there is a compelling role, I think, for those people in this industry because you can relate and you can also channel, right? And so there's a really, really interesting opera as long as people can understand what that means and how to accommodate it.
And I think that's key, John, isn't it? I mean, that's by the way, is it Jonathan or John?
Whatever. You're talking at me, I'll probably answer. That's usually 4-letter words are described.
Okay. Not late for dinner.
Exactly.
Right. But and that's an incredible point because too often and both Jim and I have discussed not so much on the show about disability and whatnot, but more, the aspect of working with somebody who's very OCD, where those skill sets really come in. I was a critical care medic for 5 years. When you're dealing with 15 pumps and vent settings and whatever other accoutrements that go along for the ride, being a little OCD is not a bad thing.
Yep, your cabinets are going to be clean.
Yeah. Well, not even the clean aspect. It's like the pump has to be right. The pumps. It's not good enough to have a drip and just have it hanging. Got to know what that drip rate is. Got to know that the drip rate's going to stay the same. How's the patient? Did I check the vitals? Did I check the vitals again? Wait, did I check the vitals the 4th time? But where it comes in from what I'm gathering from your perspective on this, or some of your experiences, is, and somewhat I've seen from the inside, is an inability or a lack of interest to deal with the polishing the gem, so to speak. They don't want to deal with it because they don't understand it, so the door remains closed. Instead of opening the door and saying, we can leverage these as assets instead of liabilities.
Jim, what were you saying there?
Who do you say doesn't want to deal with it? The person with the disability or
the organization?
That's what I thought you meant.
Right, right.
Just want to double check.
Are you asking whether I'm seeing that is a hesitation folks have?
Well, I would expect that it would be a great, a lot of times, as the story you said before, you're an accomplished businessman, you're going into a meeting, you're having a meeting with somebody, and they look at you and say, "Are you on drugs?"
Yeah, right.
I mean, it's like.
Well, let me say this: I did a survey as part of this whole thing, for asking people with ADHD some of the struggles they have and stuff, and a lot of the feedback that I got was just like you're saying, that when they do poorly on job interviews because they'll get asked a question and they'll start answering it. By the time they're halfway through the answer, they forget what the question was, and they kind of go off into places that kind of hangs them on the interview. one person says they have struggled because because of like you mentioned, Josh, management not really working with them, or field preceptors not working with them, and things like that, and they tend to struggle because of that. But once, like you had mentioned earlier, Jonathan, once they get into it, they are an asset because they are focused, and like you said, Josh, they don't let things fall through the cracks, especially if it's regimented, and the chaos of an EMS scene is almost like a comfort zone, for them.
Right.
And
I mean, I feel, one of the things that you said, John.
You filled the survey out and mentioned exactly what we're talking about. The biggest struggle that a lot of them have, it would seem pretty consistent, is when they're taking exams and when they're doing, skilled exams or written exams. That is where they struggle a lot because of other things that they have. That might be dyslexic as well. It might be OCD as well. And then it just kind of compounds on top of each other, and that's where they end up really struggling.
I have to. I very much relate, John, to your story of being how you were treated as a child, and I can only thank God that I was too early for that phase. Like there was at start the recognition, and then the therapy phase, and then let's treat it with drugs, and now there's a sort of, hey, drugs don't quite work. Let's start figuring out what we're really doing here, which is where I think we are entering into today. I think there's, I have a bunch of nieces and nephews. Several of them have learning, have some social disorders and the like. And watching them grow up, it has been a very educational experience because this has been the last 20 years has been a fucking disaster. In the sense that, let's just throw drugs at it. I have no idea where I would be today if people just threw some sort of drugs at me. I was diagnosed dyslexic, but I was really learning disabled in a different way, and it sort of came out that I was a very poor speller. What's kind of interesting, and I wanted to reflect back on what Jim said, is that a lot of these people, that have these disabilities, tend to be higher functioning, intelligent, higher functioning, a little bit above the grade. And I turn around and say, well, of course, because they have to make it not only past their disability, but they have to compete in the real world. So they're running that marathon race with a 50-pound pack on them all the time.
Absolutely. Yeah. So I think you both kind of hit the matter on the head from my view as an employer as well, by the way, is that I've been on both sides of that. And so, Jim, I think you make a very essential point in terms of this idea of, people kind of hanging themselves with their responses. There are two sides to the same coin on that, and both of which require some attention. On the one hand, I do think that employers are becoming more attuned to this, right? There's a lot of work, a lot of research at various levels, a lot of efforts through professional human resource organizations, even inside our industry, to get people comfortable talking about their experience, right? There's been some very compelling, very important work. For example, certainly we talk about post-traumatic stress and things like that, and for people to become more comfortable relaying how their own childhood experiences, for example, makes them better at what they do. That's a skill. Learning how to tell that story and bring it back to your job. And there's also a skill on the employer to learn how to say, I look at you as more than a bunch of checks on a page, right? So there's really kind of a convergence effect, I think, happening. And it's not just in our industry. This is across the board right now, that people are trying to inform their hiring practices to be more holistic, to realize that, there's there is a real challenge when you end up leaving talent on the table, so to speak, when you look just at a certain checkboxes or assume things about people. For example, out here in the Bay Area, forget disability. We have a very well documented age discrimination problem here. but age discrimination insofar as not you're too young for the job, you're too old for the job, right? And when you look at industries like healthcare and mobile medicine that have some very old legacy technology, the fact that you are 50 something, etc., that you have been coding since the 60s and 70s, dude, sign you up. Like, I want you in my team, right? Because I'm going to look at a CAD system that the fire department of New York uses and realize this thing is ancient. And if you know how to use punch cards, that's a win, right? So there is a very important to use bi-directional. I can't believe I almost said that, but it's like a dual improvement, right? On the employer side, they got to get better at looking at the person for their entire picture and sort of how they can serve the organization. It's not just a bunch of criteria. Those criteria are important, right? You got to know how to speak. You got to know how to do the medicine. You got to know how to put the IV in the person's arm if that's going to be a requirement. But beyond that, realize that, as Jim said, not every person is going to be outstanding at telling you about their life story. You've got to be humane in that regard and be able to pull that out of them, right? On the other hand, we can teach candidates to contextualize their story. I'll tell you just a brief story. I was recently looking at a candidate to work in my shop. And, obviously a pretty standard operating procedure is to get references, right? So I got 3 references from someone came to me. Not a single one of them was a professional reference. Okay, that's a little weird. So, like, you sent me to your cousin, you sent me to your neighbor, and you sent me to, someone you went to kindergarten with. That's cool. I'm glad you have friends, but that's not what I'm looking for. So I asked for 3 professional references. Red flag number 1 was that I had to correct you on that because, like, have you never applied for a job before, right? So that's 1. Red flag number 2 was I sent you. I asked you for professional references. You sent me 3 references, all of which would probably not have graded you above a 6.5 to a 7 on a scale of 10, right? So everybody knows that when you get a professional reference, these are your friends, right? Like, it's the person at the kiosk next to you, or the next cubicle rather, that is going to tell you how great you are, but they were your coworker, but you also went to lunch with them every afternoon, right? If the guy next to you uses words in your reference call like hard-headed or pig-headed, I don't know, man. Like, if that's the best you got, I'm pretty concerned about that. And so there's a skill, and it was remarkable to go through that because, to be honest, I've hired a lot of people in my day, and I don't think I've ever encountered someone who was so clueless on how to go through that process. So it was a red flag I couldn't get past. And it was, I'm sure the guy is a lovely person. I'm sure he's very good at what he does. But the candidate needs to be explained as well and taught and learned through courses and conversations like yours. Like, this is what you need to know if you want to get the gig. And it's not to say that you should lie, but if you don't have any great references, it's probably worth spinning that. Right, kind of like the classic question in every interview. Tell me the negative, right? Tell me what the person has to work on. And everybody knows that is something as managers you learn, right? To say, well, if the person, works too much, you say that they're really dedicated, right? And they're passionate. Like, right. You spew the negative into the positive, and then the employer kind of takes that, tamps it down, and reads between the lines. If the person basically says you're a jerk and that's your positive, you find some way to say my references are confidential, or I don't know anybody, or I don't have any friends, or I don't know. Yeah, I'm a loner. I'm a lone wolf. I mean, there's plenty of ways you can spin that. So I think that's something.
How old was this person? Was this an older person that has interviewed before, you think, or was this one of their first interviews?
No. This was somebody who was very advanced in his career, and it turns out that all the people that he had sent me who had hired him were people he's basically known since college. And again, I don't judge
I
that.
know
There are
that I
people.
know I get people when I do my membership site that will want me to help them with a resume, with interview stuff, and
Yeah.
they're very young, so they don't know some of the things you're talking about, how to spin certain things to make a negative into a positive and stuff like that. So I was
Well,
just
that's what I'm saying.
wondering how
I
old
think
they were.
yeah, I think that's something that they can learn. I think that, but that's my point. Like there's a meeting in the middle. If you never take have a conversation with someone like you, Jim, to explain to people how to do that, you may not know that that's kind of the unspoken expectation.
Right.
Right. When everybody has something wrong. Right. For example, I lack an off switch. Like I'm an entrepreneur. I go to sleep at 2 o'clock in the morning. I wake up at 7 o'clock, rock and roll. I'm probably in the right business for that.
Right.
Right, exactly. So I have something in common with this fellow that came to me where one of it, see, I can see I'm kind of twitchy. So if it's not you, it's not, don't adjust your monitor. That's me. So one of this guy's references said, this person works really, really long hours. And if other people are not similarly working long hours, he's going to basically feel like he's working harder than everybody else. Well, there's a thin line there. Right? If you're the person who's going to motivate your colleagues to let's go change the world, right? That's great. That's high energy and that's exciting. And we want to do a great job. And you're a fast driving guy, and whatever. Or if you're the guy who's going to shame everybody for basically saying, why am I working so hard? And you're sitting and taking a break. Maybe not. Maybe everybody's going to hate you, right? So understanding that thin line, and I think again going back to the purpose of what you were looking for, things like ADHD and OCD, right? Let's assume that somebody wants to wash their hands 9 times, check the vitals 4 times, right? That can be great from a clinical perspective, but don't expect that everybody is going to see the world your way, because they don't, right? And if I expect that you're going to, think about as an employer, reasonable accommodation, right? I'm a Tourettic. There are things that I may do. For example, when I took tests, you were talking about exams, right? When I took the GMAT to go to business school, I took it in a separate room because I'm a sniffly guy, and I didn't want to distract other people sitting with me, right? Like if I'm causing their numbers to go down because of me, well, that sucks for them, and that's not fair, right? So put me in the other room. But that's a different thing than saying, should I have a different test? Right. And I think that's a thin line because, like you say, dyslexia, maybe you do need a different test, right? Or Braille, right? Maybe you need an accommodation that's truly different, but that is something that as an employer, you have a legal responsibility for one, but also an ethical responsibility to your team, to your colleagues. Make sure that you don't hire the person because they're going to be a token, right? So you don't want to have like the token disabled person any more than you want the token black person. Right?
No, you want productivity. You want productivity, but you need to, adhere to both. Not even. I was about to say both the social norms and the laws, but you want productivity, and you have to adhere to the laws. So you have to find the best fit for your person, for that part of your organization. And and a lot of the things you touched upon are some of the reasons why the entrepreneur usually doesn't stay after the company's gone IPO. They don't, unless you're still in a growth mode, they don't want you. They want somebody to run the ship, not work all hours and brainstorm new ideas. They want to keep it on an even keel.
Let me end with a story, if you don't mind, because I know we've kept you on a long time, and I think you probably thought this was going to be shorter.
I love you. You've been great, and I hope that you come back and we can continue, especially some of this stuff about community paramedicine. But I have to jump in about 2 minutes.
Let me end that with a story that I hope you find compelling. And I really like telling the story. It's not about me.
And
One second. I'm going to make sure that my thing is ringing through. Sorry, this is probably some spam call coming through on top of everything.
Of course.
I can't find where it's ringing. It doesn't look like it's ringing. Oh, there it is. Okay. Yep. It was a spam call and my stuff deleted. All right. So a story not about me, but I hope you find it a compelling perspective to sort of bookend this discussion. Everybody watching this is going to know Walgreens, right? It was Walgreens. Yeah, I'm pretty sure it was Walgreens. So, in fact, let me double check that. Make sure I get my name right. Stand by. Because you're going to like this story. You can edit this part out, right?
As long as I get to hear it.
Walgreens, there we go. Right. So everybody in this call knows Walgreens. There was a fellow named Randy Lewis. And Randy Lewis was a top executive at Walgreens a couple years ago. And he happens to have a child who has a significant disability. And so being that he was a top executive, being that he had this personal empathy of the family member who might have been fated, doomed, if you will, whatever, to be constantly underestimated for their life. He basically, after a while, convinced his colleagues to try an experiment. And this has been well documented, by the way. It's absolutely worth looking up Randy Lewis and Walgreens. But what he wanted to do was to create a warehouse, a distribution center that was entirely staffed by people with severe disability, ranging from blindness and motion disorders to Down syndrome and cystic fibrosis, the whole gamut. And he convinced them to do it. So it's a very well publicized story that he built this warehouse and basically gave all of these folks jobs. Like the plant manager has a cognitive disorder. The epilogue to this story, and Randy I met when I was in business school, by the way. He came to the school, gave a presentation all about this and that empathy bit that we were talking about, but how it also needed to have a business benefit if you're going to convince a public company, to your point, to undertake the effort of investing in this, right? That plant ended up being the single most efficient operations distribution center in the entire Walgreens network. So much so that they created a second one. And the reason, and they may have created more, but I remember they created a second one, and it was so compelling because it turns out people who are chronically underestimated, right? We talked earlier about the chronically acute and these other ways of engaging with those patients. The people who are chronically underestimated tend to work really hard and very happily when you give them an opportunity to shine. Right. So it turned out that these folks who, you think about somebody, and we know we have this problem in America, right? Is that we have to some degree entitlement issues where, I don't want to do that job. It's beneath me, et cetera, et cetera. But if you're somebody who might otherwise not be employed, the fact that your job consists of doing this all day or checking the boxes all day, I got a job. I can pay my rent. I don't have to live with my parents because I'll never afford a job. And they were so happy.
I love the story. I got to run, not being rude. I have another at two. So
yeah,
it was an absolute pleasure. Please come back. I mean, really, truly, please come back. And Jim, I'll talk to you on the other side.
All right, Josh.
Thanks
man,
guys.
popping in. No, that's a great I guess point of view when you think about the disability aspect of things, and that was part of the reason why I wanted to do this show today, because I wanted to kind of point out that people that have disabilities, certain disabilities, can be assets to certain industries.
Some people just need a shot. Yep.
Exactly, and that's it. And like you had mentioned before about the person that was looking for the job and didn't really know how to do, the references and all, didn't know how to approach that element of it. It's the same thing with people with disabilities, right? They have to, I guess, adjust and approach things a different way so that they can get that shot and express, their value to, to a business. and that's with anything. And again, in the survey that I did, a lot of people that came back, a lot of them had said that once they had systems in place for themselves, and they had routines going on, and some of it with medication on top of that, uh, they find that they don't find it a disability as much anymore as a benefit, as a complement to what they're doing. So
Quite right.
I want to end it there, Jonathan. We've been going for a little over an hour, so I want to kind of wrap it up. So again, like Josh said, so appreciate you joining me. Great information, I think. Great points of view. Um, I hope people go check out your site, get some more information about you and what you're doing there at beyondlucidtechnologies.com. To go check that out and see what Jonathan's all about and some of the stuff that they're doing over there. I really appreciate that, Jonathan, and I'll put this in the show notes as well on the blog, your web address and whatnot, so people can go check out more information if anyone's listening to the audio version of this this episode. So thanks again, Jonathan. Do you want to wrap up with anything before we head out, or anything that's want to kind of end with?
No, just thank you for all you do, and to everyone who's listening to this. Like I say, as an industry, when you're working, we're working, and so we admire everything you're doing, especially now. It's coming at you from all angles, so those of us who are in awe of what you are doing, just thank you and appreciate it, and keep faith.
All right, everybody. That's it for me. As always, I am Jim Hoffman for EMS Office Hours. Stay safe.